All right, so let's recap this one. So dispatch to the home of a 62-year young male, short of breath. Patient sitting forward on the couch with family around. So they're giving you the position that the patient's sitting forward. Why would be some of the reasons they're sitting forward? Maybe their back is tense. Maybe they're having trouble taking a good breath if they're laying back. Maybe they have an infection around their heart, and the pendulum effect leaning forward is helping them maintain that cardiac output and good breathing with minimal pain. Uh, they state the patient is in town for the holidays and arrived 3 days ago. So been there for 3 days, acclimated to the environment. Had a 6 hour car ride after going to his dentist for a checkup. So 6 hours. So you usually get that greater than 4 hours of stasis, lacking of blood flow to the extremities. So long car ride, but 3 days ago, and then dentist for a checkup. Let's keep going through here and breaking this down. Hook him up to the monitor. Definitely tachycardic. Definitely tachypnic. That's not good with a low end title. Temps on the low end. Sat's okay. Pulse ox pleth is low amplitude, so they're constricting. Either cold extremities or shunting blood to the core. What's that pressure come back at? What is it? 117/92. Okay, so okay pressure. Map of 100's not too bad. Let's see what we get with a 12 lead here. So what are the things it could be? So it's cold, tachycardic, tachypnic, low end tidal, so poor perfusion, maybe have a pulmonary embolism. But the pulse ox is doing okay. You know, it's not in the 92s, 94s. Really tachycardic, though. Very tachycardic. 123 sitting down. That means you're running a marathon and not moving. Come over to this 12 lead here. And what do we see? Well, I like to start by arteries. So circumflex, circumflex, elevated, 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 elevated. Okay, so we have looks like about 1 millimeter of elevation in the lateral leads. Come over here, work the right coronary artery, elevation in 2, 3, AVF. Okay, so we have elevation right coronary artery, we have elevation circumflex. V1 looks depressed, depressed, V2, and remarkable in V3. Axis looks good. So in a weird way, this patient has elevations in two different areas that doesn't necessarily make sense for a heart attack unless he threw two clots at the same time, which would be impressive and suck at the same time. So this person has lots of elevation and tachycardia, got some dental work done, right? So we always talk about the staff of the mouth, the plaque, really enjoying cardiac tissue. So they said he got dental cleaning a couple days ago, stasis and a long car ride. We don't know his pinnacle of health status, but a primary concern here of mine would be pericarditis and sepsis. Sepsis be, I guess you could say number one because it's kind of the broad sweep of the broad stroke, but it'd be sepsis and pericarditis. So my primary differential would be sepsis because he meets the SIRS criteria. He has the tachycardia, the heart rate sustained greater than 90. He has the respiratory rate greater than 22. His is 33. His temp is on the low end, 98.1. So he has two of them. I don't know his white count, but his end tidal is really low. So he's almost septic shock low. And it looks like based on this blood pressure and all the other values that he's starting to teeter and where it looks like we're getting ready to tip over. So I would say septic, pericarditis would be my two working differentials. Fluid resuscitation, sepsis alert, gathering the rest of the history, getting good lung sounds, ensuring we minimize the amount of movement the patient has to do to decrease cardiac output, myocardial, and peripheral oxygen demand, and get them to a sepsis capable facility, ones that actually can monitor the patient because he's very likely going to be spending some time upstairs in the ICU. So we hope that helped. As always, if you have any questions, hit us up at info@lifelineemstraining.com, and we hope you have a great day.